Hello everyone, this is Dr. Waleed Babar once again. Today we are going to talk about a very highly topic of USMLE, which is pulmonary embolism. You are going to get a lot of questions on pulmonary embolism in your NBMEs and final exam. So let's discuss the topic in detail. Let me share my screen first. So yes, we will start with a question. As usual, we have a 70-year-old woman who brought to the emergency department because of worsening shortness of breath and lightheadedness. 4 days ago, she underwent electric total hip arthroplasty under general anesthesia and was discharged home on post-operative day 2. Earlier today, she developed sudden dyspnea with climbing a flight of stairs. Over the next hour, she became weak and confused. So shortness of breath, weakness and confusion. Her past medical history consists of hypertension, obesity, and stage 3 CKD. On arrival, temperature is 100 degrees Fahrenheit, blood pressure is 82/54, pulse is 128, respiratory rate is 30, oxygen saturation is 88 on 6-liter oxygen. She appears anxious and diaphoretic. Neck examination reveals elevated jugular venous pulsations. Uh, the cardiac examination demonstrates tachycardia without murmurs. Lungs are clear to auscultation. Operative incision is clean without surrounding arrhythmia. Her lower extremities are symmetric without edema or tenderness. WBCs are normal. Hemoglobin is mildly low. Troponin are mildly elevated. Cret is 2. Lactate 5.2. ECG demonstrates sinus tachycardia and T-wave invariant in lead V1 and V4. Portable chest X-ray shows mild atelectic changes only because of worsening hypertension. A bedside echocardiogram is obtained and demonstrates marked right ventricular dilation with reduced free wall motion and preserved apical contractility. Left ventricular systolic function is normal. Which of the following is most appropriate next step in the management? If we see option A, emergent coronary angiography, we can do it in the diagnosis of acute coronary syndrome. Let's see if this stem fulfills the criteria of having acute coronary syndrome. So first of all, the shortness of breath is there. Chest pain is not there, which is very typical of acute coronary syndrome. Another important thing is the lung auscultation. The lungs are clear to auscultation. If it's acute coronary syndrome, cardiogenic shock secondary to acute coronary syndrome, then lung must have crackles in that case. But here, the lung auscultation is clear. So this is not acute coronary. Another important hint why it's not acute coronary syndrome, because on echocardiography, the left ventricular systolic function is normal. And another important hint that this is not acute coronary syndrome is the preserved apical contractility and T-wave invariant in leads V1 and V4, not ST segment elevation or depression. Right? Now, one can say that this can be unstable angina, but unstable angina would have chest pain. The patient is not suffering from chest pain. Right? We can see that patient is not suffering from chest pain. So let's move forward. What about IV antibiotics and fluid resuscitation? You are going to tell in the comments why, when we use this intervention. Yes, you are right. This is used for septic shock, right? So let's see in the question whether the patient is having septic shock or not. In septic shock, the patient would have high fever or low temperature. The temperature is less than 98. The patient is not having that. Another important sign is elevated jugular venous pressure. In septic shock, patient will have decreased jugular venous pressure, not elevated jugular venous pressure in septic shock. So septic shock is not an option here. The IV furosemide therapy. Do you think that IV furosemide therapy is the accurate best next step? No. Patient is already suffering from shock. Patient is having decreased BP. So if we are going to give the diuretic, the BP will drop further and the patient will deteriorate. So that's why option E is incorrect, right? So we have two options. Let's make the diagnosis first. So the shortness of breath, confusion with the risk factors of recent surgery and obesity, elevated jugular venous pressure with the signs of right heart strain like sinus tachycardia, T wave invariant in leads V1 and V4 and mildly elevated troponin. And plus the echocardiographic sign of right ventricular dilatation with reduced free wall motion, which is McCollin sign, not very high yield for USMLE, but you should know in the back of your mind the diagnosis is pulmonary embolism causing obstructive shock. Obstructive shock. What other two disorders that can cause obstructive shock? The one is cardiac tamponade and one is tension pneumothorax, right? So now we have to select the best next step in the management. If you are thinking that D is the right option, you are totally wrong, because currently the patient is in shock and we do not have time to confirm the diagnosis. So we will treat this patient on the basis of the results of echocardiography. We will perform systemic thrombolytic therapy because obstructive shock occurred due to massive pulmonary embolism. And if we will delay the treatment, patient will die. So now let's discuss the pathophysiology of pulmonary embolism briefly. So the clot, because of immobility, the hypercoagulative state or obesity, pregnancy, because of these risk factors, patient would have clot in their deep veins of legs that will move into the pulmonary artery and it will obstruct the outflow of right ventricle. So that's why right ventricle will be under strain, because pulmonary artery, this is pulmonary artery, this is blocked, and right ventricle will be under high stress. This is left ventricle. Right ventricle will be under high stress and the blood will back up into the right ventricle and jugular vein. That's why we will have increased jugular venous pressure, because right ventricle cannot pump blood into the lungs and that blood cannot come into the left ventricle. We will have decreased left ventricular preload. That's why we will have decreased systemic BP and shock. I think you all will agree with me. These are some risk factors which you can read from here. You should remember these risk factors to make the diagnosis. And these are the important clinical signs and symptoms for pulmonary embolism. So now on CT pulmonary angiography, the clot will look like dark. This whitish area is the contrast, and where there will be blockage, there would be absence of contrast, and this will show that this area is having clot. So now there are two important X-ray signs which are not very high yield, but you can see 20 to 40%. You can see them in 20 to 40% of patient. One is Hampton sign, which is pulmonary shape, which is well-shaped pulmonary infarction, and the oligemia, the reduced vascular markings in the periphery of lung, which is Westermarck sign, right? These are rare, not commonly tested, but can occur in exam. So if you are having clinical suspicion of pulmonary embolism on the basis of risk factors and signs, symptoms of dyspnea, pleuritic chest pain, and hemoptysis, you are going to assess the clinical pre-test probability via Bell score or revised Geneva score. So these are the factors and these are the allocated points for each factor, whether the patient is having that or not. If the Bell score is less than 4, the pulmonary embolism is less likely, and if it's 4.5 to 6, this is moderate. So in case of low and intermediate probability, we will perform D-dimer test first. And if its score is greater than 4 and high pre-test probability is there, then we will perform CT pulmonary angiogram. CT pulmonary angiogram. Now let's move towards our algorithm. So if the pre-test probability is low or intermediate, we will perform a sensitive test, D-dimer. Because the test is highly sensitive, if it will be negative, it will rule out pulmonary embolism. But if it's positive, this will not confirm the diagnosis. So if it's positive, to confirm the diagnosis, we will need specific test, which is CTPA or V/Q scan. So if the Bell score is high, we will directly perform a specific test. So out of V/Q scan and CT pulmonary angiogram, the gold standard is CT pulmonary angiogram. But there are some contraindications to CT pulmonary angiogram. For example, if the patient is having CKD, patient is having contrast allergy, pregnancy, we will not perform CT pulmonary angiogram. In that case, we will perform V/Q scan. And if the patient is hemodynamically unstable, like in our question above, we will perform echocardiography directly to save our time. And administer the thrombolytic therapy if the patient is having massive pulmonary embolism. So these are the preferred case scenarios for V by Q scan. So if the CT pulmonary angiogram is negative, we will rule out the pulmonary embolism. If it's positive, we will confirm the diagnosis. If the V by Q scan is positive, we will confirm the diagnosis. If it's negative, we will rule out. Sometimes V by Q scan is non-diagnostic or intermediate. In that case, we will either perform CT pulmonary angiogram or we can repeat V by Q scan. So after the confirmation of pulmonary embolism diagnosis, we stratify the patients on the basis of risk of deterioration. So if the pulmonary embolism is massive or high risk, how we can decide that? These are the features. If any one of these features is present, like obstructive shock, cardiac arrest, or BP less than 90 for more than 15 minutes, then we will take this patient as high risk and we will perform systemic thrombolysis. If systemic thrombolysis is contraindicated, for example, if the patient is having BP greater than 180, systolic BP greater than 180, if the patient has recently a neurological surgery or patient is having GI bleed, then we will perform catheter-directed therapy or surgical embolectomy. If you are thinking that patient is very old and frail and patient will not get benefit from surgical embolectomy, we will insert IVC filters in that case. If the patient is intermediate or low risk, we will perform anticoagulation. These are the types of anticoagulation which we can administer to the patients, and this is the duration of different case scenarios for anticoagulation. You can read that. These are factual information. No science is that. No science in it. So this was the whole pulmonary embolism. I'm sure if you watch this whole video, you will not get your pulmonary embolism question wrong. Sometimes NBME gives you the vague statements. For example, they will tell you that patient is suffering from acute shortness of breath, low oxygen saturation, and they will just give you one risk factor, that patient is a truck driver. So you have to anticipate the pulmonary embolism. So this was from me for the pulmonary embolism. Let's meet you in another video.